So by now we are going to discuss the issue of retinopexy and how we do retinopexy during scleral buckling surgery. Our aim of adding the retinopexy is to keep an enduring bond between the retinal pigment epithelium and the choroid and the neurosensory retina, which will be persistent more than the buckling effect, which will decrease or even reduced, as Dr. Mustafa have just said. And we apply the retinopexy through three modalities. We have the diathermy, the cryopexy using the cryo application, and the diapexy with transscleral diode. In the past, we were using the diathermy through with a scleral dissection, but because of its hazardous side effect, nowadays it is not used that much because it leads to scleral destruction, shrinkage, and increase in the intraocular pressure. And it was using a high radiofrequency current, which will be transmitted into heat, leading to protein denaturation and adhesion between the retina and the choroid. The more commonly used nowadays is the cryopexy using a liquid gases with a very low boiling point as the nitrous oxide and solid carbon dioxide, forming an ice crystals at the level of the RPE and the choroid, which will lead also denaturation of the lipoprotein, leading to necrosis of this tissue and the formation of the adhesion as well. So it is applied using the indirect and the condensing lens, and it is applied over the sclera. And our aim is to do a confluent cryo application at the edges of the tear and to try to avoid the bed of the tear as much as we can, which will minimize the dispersion of viable pigment epithelial cells, which will cause postoperative epiretinal membrane formation and PVR. And as we can see, for the first instance, when we activate the cryo application, the cryo starts to occur at the level of the choroid, then it spreads to the retinal layer and to the retinal tears. And as we can see, if we have these peripheral tears, the cryo application simultaneously whiten the choroid and the retinal tissue at the same time. So when we should stop applying the cryo, it is advised to stop the cryo application just when we can see the bleaching effect over the retina. But we have another issue that we have to keep in our mind, that we have to prolong this cryo application for a little bit to induce what is called scleral translucency effect. So after we remove the cryo probe, we can find our mark, and then we can do our marking or using the diathermy to mark our tear from the scleral side. So how it looks, how the cryo reaction looks. So this is a very nice reaction for the cryo when both the choroid and the retina whiten at the same time, when we have a shallow retinal detachment with a very minimal subretinal fluid. But if we can encounter this high bullous detachment with the tear and the retina away from the choroid, usually the cryo application will show a whitening effect at the choroidal level, which precedes the appearance over the retina. And with doing more and more cryo in these patients, we can't reach the retina. And to avoid the excessive liberation of pigment epithelium, which will lead to epiretinal membrane formation, as we have heard, it is advised to do what is called a DAS technique. Actually, there is a simpler techniques that could be tried in these cases, which will reduce the intraocular pressure of those patients, and you can indent more and you can reach retina just by making the speculum of the eye, make it a little bit looser. Don't stretch the lids, which will stretch the sclera as well. So if you making the aperture of the eye less bit stretched, this may give you a sufficient indentation, which will make you can reach to the retina without doing excessive indentation. The second tool we can use before injecting the air, you can starting doing the drainage with a very small sclerotomy without injecting the air. And while you are indenting, this will allow more of the fluid to egress out from this sclerotomy, and by now you can reach without injecting the air, which may hinder your vision during the procedure. Commonly, the reactions start between 2 and 7 days for the cryopexy, and the firm adhesions occur between 2 and 4 weeks. And the disadvantages of the cryopexy is it's difficult to apply for the posterior lesions, and it does not form a maintained easily visible effect, which means when you remove the, your cryoprobe or you stop your cryo application, it is not like the PRP. You don't have a mark at this place, so you may reapply a cryo application again if you don't know how it looks after you remove your cryo application. Also, recurrent freezing Also, recurrent freezing and the freezing of the bed of large tear may induce the pigment dispersion syndrome, leading to a hazardous PVR and ERM formation. And also, it disrupts the blood-retinal barrier, which will cause cellular migration and as well PVR. And finally, the delayed choroidal adhesion compared to the laser application. And these two tips you have to avoid, the refreezing and the freezing of the bed of the large tear. And what is important to avoid what is called a shaft indentation. So you have to indent using the tip. And as we can see in this video, slow motion, this surgeon was trying to reach this bullous detachment, and he was doing this cryo application using the shaft, which may inadvertently lead to a cryo scar at the macula or even at the optic disc. The third tool is the transscleral diode, and it uses 810 infrared laser, which will cause protein denaturation. And it is applied transsclerally with a red beam as the PRP we are doing everywhere. We're starting with a 500 milliwatt for 2 seconds, and you may increase by 250 milliseconds. You can only apply a transscleral diode if you have a very short detachment, so you can indent and reach the retina, or if it is a bullous, you have to do a subretinal drainage to reach the retina. And it starts on the first day of application to form the adhesion, and it is firmly adherent by the second week. Its disadvantages is not suitable for blunt fundus as RP atrophy, and it may cause scleral thinning with retreatment. So how do we select between diode and the cryo? If we have a large extensive break, it is advised to have the diode to avoid the pigment dispersion, and it may allow you to do retreatment over the buccal. But the cryo, it is preferred for small breaks, especially if it is hard to find the break, which you may need to lighten up your break using the cryotherapy, and it is more advantageous in media opacity and the blunt fundus pigment atrophy. And finally, there was a study that comparing the two treatment modalities, and there was no significant differences between the reattachment and the cryo adhesion it forms after the treatment application. And finally, thank you.